We're going to chat about a thing called TeachBox that you probably haven't heard of previously, but we'll have a chat about it. Probably by way of background, it's worth mentioning where the organisation I work for operates. And we've put a few examples for you. So we work with the Red Cross in Lebanon. So we work with their emergency management departments, their emergency medical department, and their disaster response departments. So that's all around kind of community delivery through NGOs. We work with Robert Gordon University. That's mostly about what we like to call good medicine in bad places. So it's invariably about taking normal medicine and applying it in a pre-hospital setting, in technical rescue, in disaster, in those kinds of things. So that's our kind of academic link primarily. We work a lot with helicopter search and rescue in the UK, which is all around teaching and doing CME for the boys and girls that fly around in helicopters over the sea and pull people out and do dangerous and complex things. And the reason I've put this one here is because this is kind of the step-off point to where TeachBox came from. Enable, the Belgian development agency, great organisation based here, the Ugandan department based here, and we came over a few years ago to do some emergency medical training funded by those guys. And we went to Fort Portal, Bawera, Madigo, so 4, 2 and 3 is where we were providing the practical hands-on training for emergency medicine for clinics invariably who were seeing the kinds of patients they weren't used to seeing. So becoming a little bit overwhelmed with more emergency than they were used to, and doctors who weren't specialists in emergency suddenly finding themselves on the front line of lots of influx. I'm sure you're all very familiar with the story. So for those people, we went and we targeted 38 of them. We took 38 doctors and nurses and put them through a reasonably intense programme in which they did all of the hands-on practical, this is how you stick knives in there and tubes in there and all those kinds of bits and pieces to fix people. 38 of them trained. Once we finished that training, Enable asked us to get involved in coaching and mentorship through an online system. It was a little bit fantastical, really, to hope that we could go as far north as you can get in this country and provide normal online systems exactly as you get here. It just wasn't realistic. But we kind of, problem solvers, so we figured we try and work our way around it. So we built the normal online platform for education, which was a document repository, a whole bunch of training videos and exercises, the PowerPoint presentation type things, PDFs, etc. And then we had a Skype link up and a WhatsApp link up so as we could then coach the individuals that were going through the program. So it wasn't everybody that we put through the program. Everyone had got access, but actually there were only 6 mentors that could really use this system. So for each of the clinics, you had 2 mentors. The 2 mentors would access the system, do a CME, and in order to run the program, they'd be able to click it onto the screen, play the videos, show the documents, and they'd be able to do local training, which resulted in 3 months. Instead of just the 38 that we've been out and trained, we popped that up to, or they popped that up with some support of 462 trained, with literally no cost impact because it had been dealt with entirely locally just using an online system. For those of you that have done any kind of IT work, particularly in this country, or particularly in the north of this country, it's quite hard to get your hands on hardware. It's quite hard to get your hands on computers that will be reliable, that aren't just reliable as in you've got them because they're in your hand, but you've got them, no one else is using them, they haven't disappeared off into a different department, they're not so packed with data, we saw this a lot, so packed with data that they don't work. They just keep coming up with error messages, and although you've got a computer, it just doesn't function. So there's limited access to, but also just to try and buy them in the first place obviously is costing a fortune. Not everybody that we were meeting had got full computer competence. They certainly didn't know necessarily how to work their way through the error messages that come up about every 15 seconds on a Windows laptop, which I'm sure you're all familiar with. A really key point for us is that when we were looking at hardware, we were looking at tablets, and most tablets, especially the affordable ones, can't be connected to a projector. You can't connect it to one of these. And that's a little nightmare in itself. Organisationally for the hardware manufacturers, what they're trying to do is get everybody to use Wi-Fi and use data, etc. Well, in places like this, you can't just rely on Wi-Fi and data all the time, so we need things to be a bit more sensible. We need to be able to plug one cable into a computer and get it up onto the screen. Internet, obviously internet access is a really difficult thing when we're trying to do online training. Costs a lot, and if you use things like the online training platforms like Moodle, for example, or YouTube or any of those things, downloading is a real difficulty. Sometimes you can download, sometimes it's restricted, sometimes it isn't. But to be able to download the programs and watch them causes two issues. Firstly, normally you can't, so you just have to do streaming. So you have to watch the buffered version of the video, a little bit like the video we've just seen, where it kind of struggles and then catches up and struggles and catches up. There's also a huge cost implication of repetitive downloads. So if you want to show the videos more than once, you've got to download them every time you want to show them. You've got to use data to be able to show them, which is very unhelpful. Obviously, we all know about network unreliability and then the cost of it. Worthy of note that most of the doctors that were in the clinics we were working in were using their own telephones as hotspots to access data on computers, sorry, on the internet, because the clinics that they were working for just didn't have quite enough data to be able to hand out in that way. If you do put things out on the internet generally, they're really hard to govern. The first thing is it's hard to keep control of content, and what that means is that if you release version 1, then it goes out, it gets downloaded, it's on people's laptops and phones and everything else, and then 6 months later, when you've put out version 1.1 to reflect the new guidelines, people are still watching version 1, and it just keeps going in that way. So it's really hard to keep control of it, and certainly in terms of compliance, that's a problem. Really hard to receive feedback. Most systems, most platforms use the thumbs up or thumbs down method. I don't think that's, I'll be guided by Professor Jones, but I'm told that that's not a great way to gather feedback and data, etc. You can't version control the downloaded material. And one of the things we also noted is that when you just stick everything up there, your facilitators, your local trainers, don't necessarily follow the chronological attempts that the education's been designed to follow. So what they'll do quite often is get to a bit that they don't like or don't fully understand, and just kind of step over it and move on to the next bit, and then talk a lot about the things that they really do understand. So not that helpful in kind of trying to make sure that we govern the system. Data collection is pretty important, particularly important for donor organisations that want to know what you're doing with the work that you've created. So if you've done a load of education work, who's it gone to? Were they male? Were they female? What was their location? What was their clinical grade? What did they think of the course at the end of it? So all of those data collection parts that we normally see, you can't do on a standard system. We decided therefore to make a TeachBox. And a TeachBox is a thing where we set out alongside Enable, the Belgian Development Agency. We took a lot of input from those guys and from the clinics that we've worked in and from Professor Jones and others. And we decided there's a few absolute musts of how this is going to happen. So whatever we do, it's going to have to be interactive. We can't rely on data all the time, so you must be able to operate this thing offline or online. It needs to be able to plug into things, so we need maximum connectivity both upstream and downstream. So we need to be able to plug things in, and we also need to be able to take data and get it onto the system effectively. It needs to enforce the chronological compliance, so what we've just said about working your way through. If you're the tutor, we want you to teach every element, not just the ones you like. So that's what we mean by that. Sustainable in that we'd like it to carry on working. You'll understand the term sustainable, I'm sure. And we wanted to make data collection easy. What we've seen from a lot of the work is there's paperwork. I'm sure you've all seen lots of data collection paperwork, which is really hard to both pull in. Then you need to pay somebody to assess through it and do all those bits and pieces. What we were saying is, well, we'd like it to be easy. However that data is collected, both feedback and otherwise, needs to be simple. We said it can't be expensive. Whatever happens, it can't be the cost that ordinarily you'd see out there in the world. And we said it can't cost delegates anything. It can't cost the doctors who are doing the teaching money in order to be able to do the teaching. That was a thing that we really wanted to get round. It can't require complex IT skills, because so many of the people we met didn't have complex IT skills, And it can't be single use. It can't be a watch it, burn it, and it's gone away. So we did it, I'll show you the easiest. So we made a TeachBox, literally a TeachBox, which is one of those. Slightly different to most tablets that you'll see. I put it on the screen just so as we can have a chat through it, but it starts life like that. There's the tablet. The organisation allows you to log on to it through the subscription process. You type in your username and password, your CPD number if you've got one, those kinds of things. It can link to all of those things so it can capture the fact that you're using this thing to teach with. As I said, we wanted to connect, so it really does connect. It's got pretty much every kind of connection you could ever imagine. If you look down the side of it, what we've got is just every port. You've got HDMI and sound and mini USB and USB, and you can stick a data card in it, and it's got its own power source. It's actually got 2 plug-in power sources, because we always find that they're a little bit unreliable. Bluetooth, Wi-Fi, you can get data on it and you can display data from it, and that's the thing that we found bizarrely hard to just go and buy in the street, hence we ended up with that thing. Connect it to a telly or a projector or to a monitor. That doesn't mean it works on a computer, it just means you can use it on a computer monitor, so it becomes fairly easy to do. The way it works is this: an authoring organisation says, we'd like to do this, whatever it is, we'd like to teach this thing. They come to us, and what we do is help them create that. And then the way we're looking at it at the moment is that goes to probably local hubs, probably local clinics that have got something like that in them, which is a Wi-Fi box. So it's got a data card in it, so you can hop into the clinic and upload and download your TeachBox from one of those locally, but it means you're definitely not going to have to use your own data. However many facilitators you choose are given a TeachBox, and then what they do is they go and use that TeachBox to teach delegates wherever they like. And you know, in terms of governance, that they're teaching precisely what you want them taught to the appropriate level, governed in an effective way. It looks like that. This is, so you go into a session called Biomass Smoke. Let's say this is a course called Biomass Smoke. And what the operator does is, you've got a bunch of units inside of it. They can either download the individual sessions. Bearing in mind, we're looking for efficiency when we're using data. We don't want to be spending data for no reason. So you can either download the individual session, or you can download all sessions for an individual course. But what it means is you'll go to the clinic, download it, and then you can go away and teach it. You can't just teach it though. We decided that alongside Enable, there were a few things that needed to happen first. If you want to teach it, you need to prepare for it first. So it means you're going to have to do a little bit of background work on what is the subject I'm teaching, and what's the content, and how's it going to work, and what are the learning objectives, what resources do I need, all of those things that allow you to prepare for delivering the session. And only when you've completed the session preparation section does it allow you to tap the button to say deliver this session. So you've got to be prepared before you do the delivery. Again, that was fairly important, particularly for the donor side. They were particularly interested that people were really quite prepared to deliver. When you go into preparation, it gives you a range of activities, and obviously depending on what you want to teach, you can choose any number of these, but videos and reading and demonstrations of practicals taking place. So videoed versions of practicals taking place was really important. We were doing some things where we needed to cut holes in people's necks. Trying to demonstrate that or trying to demonstrate the demonstration of that is quite hard. Demonstrating this is how you do it, well that's fairly simple. But demonstrating this is how you demonstrate, that's quite difficult. So what you end up with is a camera like this, filming the demonstration taking place. So when you do it, you've already seen essentially the course running before you. Audio lectures if you want them, and then you can stick in things like confirmatory quizzes, so you can make sure that the person that's delivering it is definitely at the level you want them to be at. This is the kind of preparatory things that people will mention.
In utero and in early childhood. Biomass smoke results from the burning of organic matter, such as wood, crop residues, vegetation, and animal dung. Biomass is primarily used in middle and low-income countries, Asia and South America, for example. In Africa, 80% of the population use biomass. That's around 657 million people. In Uganda, more than 90% of households use biomass. Worldwide, 4 million people die every year prematurely due to household air pollution from biomass smoke. More than 50% of those deaths are due to pneumonia attributed directly to biomass smoke. 3.8 million deaths from non-communicable diseases such as stroke, ischemic heart disease, COPD and lung cancer are also attributed to biomass smoke. Other health problems include a low birth weight, tuberculosis, cataracts, nasopharyngeal and laryngeal cancers. Women and children are most affected because they spend the greatest time around the fireplaces. Burning biomass gives rise to high levels of household air pollution, including small particles that penetrate into the lungs. The particles and other pollutants lead to inflammation of the airways and of the lungs, an impaired immune response, and a reduction in the oxygen carrying capability of the blood. Lung growth in babies is reduced. Babies are born smaller, often prematurely, and there is an increase in incidence of stillborn babies. Even in early life, biomass smoke damages the defense mechanisms of children. They have an increased risk of acute respiratory infections, and when they do suffer infections, there's a greater risk of those infections becoming more serious, for example, causing pneumonia. Biomass causes a vicious cycle of illness. Children are born with smaller lungs than usual. When these lungs become infected, it causes damage to the lining of the airways. They are less able to clear the infection, which means they're more likely to have a prolonged or worsened infection, which in turn causes greater damage to the lungs and to the airways.
You get the idea with that kind of video footage. What we're doing is teaching the general stuff. We're not teaching directly to an individual, and it's not a taught lecture. It's usually about developing a broad idea of this is what the subject is and this is what we'd like you to understand. You can put a bunch of documents in preparation as well if you choose, if you want people to read specifics. When it comes to delivery, it's exactly the same thing. We've got the same setup where this time what you're doing, because you've done your preparation, you now plug the machine in and away you go. The first thing to do is register the delegates. And registering the delegates is pretty important because firstly we need to know who's doing the courses, but also we need to get this bit. I'm sure you've all become very familiar with the concept of consent, and consent becomes huge because we're gathering data. A lot of the donor organisations will be European and therefore work with GDPR. GDPR essentially means every organisation, if they're holding data of any kind, need to be really careful, respectful and not accidentally or otherwise let that data out into the public. So it becomes really important that although the donor organisations and the delivery organisations really want to capture all of this, we need to make sure that what we're doing is getting the people to register in the right way and agree to, for example, if you're going to do some research on the delegate group, we need them to agree to do that first. So registering the delegates becomes quite important. Then for example, we've got taught video sections. You might recognise the guy doing this.
Welcome to Unit 2.1, Health Impacts of Household Air Pollution. The purpose of this unit is to equip community health extension workers with knowledge of the health symptoms experienced by people exposed to household air pollution, as well as the serious short-term and longer-term health impacts, including respiratory, circulatory, cancer, eye disease, and adverse pregnancy outcomes. The unit will take around 90 minutes to complete and will include videos, case studies of patient stories, facilitated discussions, and a mini lecture. By the end of this unit, you should be able to show a basic understanding of the mechanisms by which household air pollution exposure affects the lungs, other organs of the body, and the unborn child. You should be able to describe the major disease conditions for which there is good causal evidence of a link with household air pollution exposure. You should be able to show awareness of other disease conditions for which there is strong suggestive evidence. And you should have awareness of the WHO burden of disease calculations and the approximate disease burden caused by HAP globally, regionally in Africa, and nationally in Kenya. We'll begin by showing a video from Plymouth University in the UK entitled...
I'm not going to make you watch all of that, I'm sure your ears would fall off. But the point of that is it's a talk session. It won't necessarily be me teaching it. If it's about lungs, I'll ask Professor Jones to be the guy that does the teaching. If it's about TB, I'll ask Dr. Bruce to do the teaching. If it's about teaching to camera, I'll ask Wincy to do it because he's amazing at it, honestly. What you end up with is the right people teaching the right subjects straight to camera. So everyone that gets taught by the same person. And it becomes almost the truth. It becomes the way to have the right people in the right place, delivering the right content. What we know from feedback, we took a lot of feedback from the clinics that we were teaching in before, and they really liked that concept. We did a whole bunch with Dr. Keir Phillip, Professor Jones. They did some respiratory work for us, taught straight to camera, and it went down incredibly well. The delegates really liked it, but so do the facilitators, the people who are doing the teaching, because frankly they trust the people on the screen. They know that they really are the real deal, they're not just some random presenter. What we need to do is engage the people who are doing the facilitation though, in such a way they really are an important and intrinsic element of the teaching. What we don't want is somebody that stood there pressing the go button. You know, if we just need the go button doing, then that would be kind of too easy, and we don't think it would achieve the objective. What we want instead is facilitators, tutors who are really desperately involved. They're a huge part of it. So this kind of thing is where the facilitators will lead a Q&A session, or they'll lead a discussion session, or they'll lead a practical session, a demonstration, you know? All of the things where the facilitator becomes the real conduit for confirming the education and reinforcing the education that they've picked up on the video. What it also means is that they won't be able to deviate from the script very much. What they'll be able to do is do precisely what's written there, what kind of fuels and technologies are used, for example. They have the conversation around the room, they fill it all in on the paperwork, and then the facilitator's got the ability to reveal the answers. So you don't end up with this lack of confidence in facilitators who are teaching things that they're not really too sure about. Because if they are asking questions, as in the previous slide, it's okay, we're not going to try and expose you and make you look a little bit confused. What we're going to do is give you the answers to make sure that you can have all the conversation in the world, but you've got a safety blanket of being able to reveal the proper answer. Again, really well received by the delegates. And then we grab the information back from them. At the end of the session, everybody has to stand up, come over and tap their buttons. What do you think? Do you think it was good, bad or indifferent? And then you as the authoring organisation will choose what questions you want in here. Again, I'm becoming increasingly aware that academic people really like getting the question right. It's far beyond me, I don't understand it, but apparently getting the question perfect is very important. So we like to do that and give you the opportunity to ask whichever questions you like. In terms of what we're doing with it next, we're doing some here through Recharge for respiratory health. Dr. Bruce, Dr. Wincy are doing the Recharge program, which is around, well, it's fairly self-explanatory. It's about pushing the message out in a kind of locally autonomous way. The Red Cross in Lebanon, which is where I seem to spend too much of my time, 2 parts to that. The Community Resilience Programme and then the Emergency Medical Training Programme. They're having those 2 spread out as well. Next week it's Kenya for the Community Health Extension Workers Programme, and that's looking at the a national rollout of a huge project about everything from, it starts with, as you can probably tell, biomass, smoke and lung health, but that extends to all manner of medical and community-based education. So we'll know more about that next week, but we're off to go and have a conversation to find out whether or not this is the appropriate delivery method for the education systems that they want to put in place. And then home for me, we'll be developing the United Kingdom's ambulance services clinical guidelines into 2 parts. We'll be doing it in terms of delivery, so their local level people can deliver clinical education, but then there's also I'll show you in fact as we go on to here, the next phase of this is what's called TeachBox Delegate, and TeachBox Delegate is all around you being able to use your own telephone, for example, to teach yourself through the same videos, same content, but it won't be as well governed. All it'll mean is you can sit there and do CPD from your telephone that's directly linked to the TeachBox system, which therefore will link to your own CPD system. So it's about being able to push it out pre-work, so before you come on a course, you might have to go and do some work on your own telephone, or your own computer, etc. And it will record that work that you do. So a blended system, online and offline, in order to reduce that cost. Governing that education as tightly as we can do, but whilst really making sure that the people who deliver the courses are utterly engaged and involved in the delivery, not just a spare part, an absolutely essential piece of it. Obviously you can teach any subject you like through it. I don't know what your particular specialisms are, but there's anything you like. And then what we're trying to get to is the point of national and international best practice, but delivered locally by your own staff with minimum miles, minimum data, and all that stuff. So you end up with these 3, for example, teaching one subject, international brilliance, delivered in the most rural and remote locations in a place that we couldn't normally get to. Was that fast enough?
Yeah, thank you.
Anyone hear anything?